So the topic of the today is the low risk prostate cancer, post-radical prostatectomy, local recurrence with high risk features N0 M0. And I am going to speak for the chemotherapy. So again, the most important trial for this setting is the Stampede trial. It is published in Lancet 2016. And it is a very complex trial, but again, this is in this trial there is a recurrent prostate cancer is the one of a very important part in the at least in all arms. The study design and participant, and in this design the participants are included are previously treated with radical surgery relapsing with high risk feature is the one of the main patient in this settings. So in trial, the allocation was in the 2:1:1 ratio to standard of care only, standard of care plus zoledronic acid, standard of care plus docetaxel, or standard of care plus zoledronic acid and docetaxel. Procedures: radiotherapy at 6 to 9 months after randomization was encouraged for the patient with N0 M0 disease until November 2011, and after that November 2011 it is mandated, so it is compulsory. Outcomes: the definitive and intermediate primary outcomes measures were overall survival and failure-free survival. So this is the total number of patients in this trial was 3,983, and arm C and E include the docetaxel in their treatment, and 592 patients in the arm C and 593 patients in arm E. The median follow-up of this study was 43 months, and you can see in all arms around 44% patients and 45% in the N0 category. It is the topic of this debate. And 456, 77% patients assigned to the standard of care plus docetaxel, and 422 patients, 71% to standard of care plus zoledronic acid and docetaxel received the full 6 cycles. So you can say that more than 70% able to complete 6 cycles of the docetaxel. And use of standard care radiotherapy was similar across all groups, around 28 to 29%. So for radiotherapy, 131, 57% for standard of care plus docetaxel, and 130, 57% for standard of care plus zoledronic acid and docetaxel. Higher proportion of N0 patients than the N plus patients received radiotherapy. You can see in node negative patient who received radiotherapy is around 71% and 61% in both docetaxel. So the results: standard of care only, median survival was 71 months and 5-year survival was 55%. Standard of care plus zoledronic acid, 5-year survival was 57%. Standard of care for docetaxel, 5-year survival was 63%. And standard of care for zoledronic acid and docetaxel, 5-year survival was 60%. So this is showing zoledronic acid not playing any significant role, no role in the increasing the survival with docetaxel. You can see the both curve, failure-free survival and overall survival, which is showing it is superior for the docetaxel based treatment. So docetaxel improved failure-free survival for non-metastatic disease and metastatic disease both. You can see the forest plot, and you can see the N0 patients. The diamond is in the favorable side. So addition of docetaxel to standard of care was associated with improved survival with HR of 0.78 and difference to median survival for 10 months, as well as improvement in the prostate cancer specific survival, failure-free survival, and skeletal related event for the whole set of the patients. And also docetaxel was well tolerated in this population as per this study patients. Some important points: the beneficial effect on survival is clear in the largest metastatic subpopulation, which accounted for 61% of the patient in the trial and 84% of death. There were fewer patients in non-metastatic disease, and with their generally more favorable prognosis, there were relatively few deaths in this group, and all survival analysis for this subset are currently underpowered. So in this non-metastatic subset of men, death from the cause other than prostate cancer were more common than in the men with metastatic disease, and therefore any effect of docetaxel on overall survival will be diluted. We will report longer term follow-up in due course, but note that estimates of the treatment effect in the failure-free survival and prostate cancer specific survival are extremely similar for the patient with and without metastasis at presentation. So we will get more results in due course. So in the non-metastatic setting, there are insufficient mature survival results in the literature. So further follow-up and engagement in the planned metastasis are needed to further delineate the effect of docetaxel on survival in this setting. The impact on failure-free survival is both clear and large in the favor of docetaxel in STEMPEDE trial. So in conclusion, standard of care should be updated to include docetaxel chemotherapy in suitable patients with metastatic disease, and docetaxel may be considered for the men with high-risk non-metastatic prostate cancer or without radiotherapy. For the cost effectiveness, docetaxel is cost effective among patients with non-metastatic and metastatic prostate cancer in a UK setting. One more very important trial. This is phase 3 in RG Oncology RTOG 0521 trial. In this patient and methods, this study enrolled patients with the high risk non-metastatic disease between 2005 and 2009. Patients were randomly assigned to receive standard long-term androgen suppression plus radiotherapy with or without adjuvant chemotherapy. Patient and methods. This patient include no one of the important inclusion criteria is no evidence of nodal or distant metastasis by axial imaging or bone scan. The primary endpoint was overall survival. Again, the total number of patients for this study was 563, and with RT arm it is 281, androgen suppression RT and chemotherapy arm 282 patients. Median it was 66 years in both arms. Chemotherapy was started 26 to 33 days after RT and consisted of 6 cycles of docetaxel 75 mg per meter square intravenously over 1 hour every 21 days, and prednisone 10 mg only daily until 21 days after the last cycle of chemotherapy. Median follow-up was 5.7 years. 4 and 6 year overall survival was 88.7 and 80.6 arm for the androgen suppression RT arm, and 93.3 and 86% in the chemotherapy arm. P value was 0.34. You can see the curve, the superior curve for the
Dr. Mishra, your time is up, sir.
Just 1 minute. So this, again, we want to just summarize. Conclusion that the patient were the high risk non-metastatic prostate cancer, CT docetaxel improved survival from 89 to 93% of 4 years. And again, it is included in you can say NCCN guideline. The panel recommends the addition of docetaxel added to EBRT and 2 years of ADT as an option for the patient very high risk prostate cancer. And again, there is a available tissue-based test also. There's role of biomarkers, which is now in future decide what is the role of the docetaxel, and these are the DECIFER included the post-RT patients. And this is a trial ongoing in RGCI RC 002, and very important. This is one of the inclusion criteria is available surgical formalin fixed paraffin mediated specimen for genomic analysis on DECIFER genomic resource information database platform. So I want to just say this docetaxel is very important for recommended our subset of the patient. Thank you.
May I now invite Dr. Amal to speak in favor of radiotherapy?
Yeah, I would request the slides to be shown, please. I would like to thank Dr. Manish Pandey and organizers for giving me an opportunity. Although I feel that this is not a debatable topic in the sense that it is well known to all of us that local control is paramount when we want to control a disease, whether distant or otherwise. So I would like to highlight what are the pathological high-risk features actually post-radical prostatectomy, that is T3, T4, positive margins, grade group 4, 5, and lymph node involvement. Next. Now, in PT3 status, 50 to 75% of the men with pathological T3 disease will have a biochemical relapse. What is the impact of positive margins? The natural history with positive margins is variable, and the impact of positive surgical margins and adjuvant therapy requires recognition of factors that are modifiable as well as non-modifiable. Non-modifiable factors are largely due to inherent biology of the disease and will drive both recurrence rates and impact adjuvant therapy has on the course of disease. Next. Next slide, please. Now comes the primary Gleason's score at the positive surgical margin influences the likelihood of systemic progression and cancer-specific survival. This is a third point. Now, in one of the studies, 1,036 odd patients post-radical prostatectomy, median follow-up of 13 years, 33% had a positive margins. Gleason's grade 4 at the resection margin was associated with worse systemic DFS compared with grade 3. Gleason's grade 3. Next slide, please. Extended follow-up from the large clinical trials provide evidence that PORT is well tolerated and improves biochemical local control rates as well as metastasis-free and overall survival in men who are found to have P3 disease or diffusely positive resection margin at radical prostatectomy. Now, management. For PT3, negative nodes, negative or minimally positive surgical margins, and undetectable serum PSA, post-operative radiotherapy is recommended. The bigger question is adjuvant or early salvage radiotherapy. This issue has been addressed mainly in 3 trials: Radicals RT, next slide please, Radicals RT, RAVES, and multicenter French Getting AFU 17 trial. These 3 trials and meta-analysis of the same, totaling around 2,153 patients, out of them 1,000 odd received adjuvant radiation and 1,077 early salvage RT. It was concluded that there was no evidence that adjuvant RT improved event-free survival compared to early salvage RT. So early salvage RT at the first sign of PSA recurrence is the standard of care or recommended rather than adjuvant RT. Next slide, please. Next slide, please. So men with higher risk disease, what are they? Just now we spoke about PT3 and Wajima. So extensively positive margins, especially with grade group 4 or 5 disease. These patients can have a rapid rise in PSA given the delay associated with delivery of salvage RT relative to adjuvant RT, because the disease within the RT volume may spread outside the treatment volume during that time. In these patients, one may consider adjuvant external RT rather than salvage at the first sign of biochemical recurrence. Next, please. Next, please. So benefit of adjuvant RT was shown in SWOG trial 8794, 425 men randomly assigned to immediate RT or observation. The result was that adjuvant RT significantly improved metastasis-free and overall survival compared to observation. Next slide, please. In a multi-institutional analysis of 26,000 men with T2, T3, N1, M0, there were 2 subsets, 24 with adverse pathologic features, that is PN1, grade group 4, 5, T3, T4, 428 underwent adjuvant RT, 1031 had early salvage RT, and 965 received no RT. Next slide. And without adverse pathology, 391 adjuvant, 3570 salvage, and 19,733 no RT. Adjuvant RT significantly reduced all-cause mortality compared with early salvage RT in men with adverse pathologic features, including those with PN1 disease. Without PN1 disease, 10-year cause mortality 5 versus 22%. By contrast, there was no significant difference in all-cause mortality with adjuvant RT among men without adverse pathology. Next slide, please. So patients with detectable post-operative PSA, particularly above 0.2 nanogram per ml, are candidates for salvage RT, may also be candidates for additional staging workup, including PET, which we all know. Given the risk of an early rapid increase, the option of adjuvant RT should be discussed with men who have extensively gross positive surgical margins, especially in conjunction with grade group 4 and 5 disease. Next slide. Concurrent androgen deprivation use is controversial outside the context of a clinical trial. Factors which support use of concurrent adjuvant androgen therapy is extensive extraprostatic disease, seminal vesicle involvement, high pre-salvage RT-PSA level, and presence of grade group 4 and 5 disease. Next. Two trials from RTOG, 9601 and the another trial, they do not provide a clear-cut answer whether adding adjuvant. In 9601, actually, they showed that there was a 12-year actuarial overall survival was better with adjuvant bicalutamide. Next slide. But actually, when it was analyzed, it was found that residual elevation in the serum PSA. They had patients which had already residual elevation in serum PSA, as well as those in whom the PSA subsequently rose. So actually, it was found in a post ad hoc subset analysis that PSA less than 0.7 did not benefit from adjuvant bicalutamide compared to RT alone. Similarly, RTOG 0534. In this also, there was evident benefit with bicalutamide was not seen compared to the RT because the arms were mismatched. Some got only the prostate bed RT, some got along with pelvic nodal RT. So it could not be head-on, the head-on comparison could not be done. Next slide, please. I think I can skip it away. It is quite clear that we don't have still a data that one should use systemic therapy over radiation therapy alone. The Mayo Clinic data shows that between 1991, 580 men underwent following post-radical prostatectomy, N0 received adjuvant ADT only, and 1160 were managed expectantly without adjuvant ADT. Next slide, please. Next slide. Yeah, of those managed without adjuvant therapy, 30% subsequent. Can you go back, please? 30% subsequently received ADT for either biochemical or systemic recurrence. Adjuvant ADT was associated statistically significant. Chemical and systemic progression-free survival compared with delayed treatment. However, there was no improvement in overall survival. Next slide, please. This is another trial, early prostate cancer program trial. In this, 8,000 odd men with localized or locally advanced non-metastatic prostate cancer received bicalutamide, and it was added to watchful waiting, radical prostatectomy, or RT. At a median follow-up of 10 years, bicalutamide did show a statistically significant improvement in progression-free survival in specifically T3, T4 disease. Next slide, please. There was no significant difference in overall survival. Next. In fact,
Dr.
in
Amal,
this
your time is
patient,
over. Can you please summarize, sir?
yeah. So this is the last part of the presentation, that in lymph node involvement also, what is the data with relation to radiation therapy? So although the optimal management is not defined, next slide, Retrospective large series suggests that adjuvant RT can improve outcome in patients. And Stampede trial has been already explained regarding that it has shown benefit in patients which are having high risk disease. Next slide, please. So adjuvant RT alone, 1,011 men treated between 87 to 2012. 88% received adjuvant hormonal therapy, 9% received adjuvant RT. The rate of biochemical recurrence at 15%, 15 years was 52%, and clinical recurrence was 33%. Next slide, please. Factors associated with increased risk of recurrence on multivariate analysis showed that the omission of adjuvant RT was one of the factors which were associated with increased risk of recurrence. Next slide, please. This was another study of 1,338 patients. Initial management was observation, ADT, and RT plus ADT. ADT plus RT was associated with significantly improved OS compared with observation. And another study of 26,000 men in which patients underwent radical prostatectomy and pelvic lymphadenectomy. Next slide, please. In adjusted analysis, after excluding men with persistently positive PSA level, adjuvant RT significantly reduced all-cause mortality compared with early salvage RT in men with adverse pathologic features, including those with PN1 disease.
Sir,
Next
please
slide,
wind
please.
up.
Yeah, next slide, please. Next slide. This is another trial, but its time is short. Next slide. Yeah, that's it. Thank you.
Thank you so